right, everybody, if you can grab a seat. We're going to get rolling here with our next expert panel on emerging treatments for major lung disorders. My name is Jason Gerberry. I am one of the Biopharma analysts at Bank of America, joined by my colleague Alec Stranahan, another Biopharma analyst at BofA. We'll co-moderate this panel. Wide range of topics to talk about. I thought maybe first we could kick it off with what historically had been the graveyard for drug development, which is IPF. And we've had two positive trials of recent, Boehringer Ingelheim's nerandomilast, and more recently, United Therapeutics top-line positive phase 3 data for Tyvaso. It's a drug that you're very familiar with in other settings. So maybe, Aaron, if you want to introduce yourself, and then maybe we can just jump into, at the ERS medical meeting later this month, we're going to get some important data sets. What you're most excited about, and then we'll get into IPF more specifically.
Sure. So I'm Aaron Waxman. I run the pulmonary vascular disease program at the Brigham and Women's Hospital. I've been involved with a lot of the clinical trials, peripherally with ILD, because a lot of that came out of our efforts with inhaled treprostinil in pulmonary hypertension, and especially pulmonary hypertension in the setting of interstitial lung disease, where we saw initially a marked actual improvement in lung function in those patients with PH-ILD after a year of treatment. So it spun off to the Teton trial, which you're referring to. Teton 2 was just announced. It's not in the US or Canada, but they did have a positive result. The other study you're talking about is the phosphodiesterase 4B inhibitor, which has also been studied in ILD. I think the two studies themselves looked at the same population of patients, but had, I would say, quite different results. The results with Teton were, I always try to temper the excitement because we're talking about a delay in progression of disease. And with the Teton study with inhaled treprostinil, the delay was about 100 cc's better lung function compared to placebo. It was about 98 cc's. Whereas with the PDE4B inhibitor, it's about 65, 68 cc difference. So yeah, those things do work. They do slow progression. Tolerance-wise, the PDE4 has similar side effects that the current state-of-the-art has. Whereas treprostinil, probably the biggest issue is cough, and if you can get your patients over the cough, they do fine, and we're pretty good at doing that at this point.
Okay, and maybe stepping back, how bad, if we want to set sort of what's the unmet need in IPF and how bad current antifibrotic therapies are, or maybe not that they're bad, but how intolerable are these therapies? I mean, we've heard anecdotes that, as many as a third of patients just can't tolerate these therapies, and patients are just on no therapies out there. Is that something that you can corroborate through your own experience, and just thinking about the role that these new therapies can step into?
Yeah, so I think the best example of the tolerance is when you look at the actual INCREASE trial, which was PH-ILD, but nonetheless it was an ILD population of over 300 patients. And everyone could be on background antifibrotic, but because of tolerability, only about 20% of the patients actually were able to stay on antifibrotics through that study. So it is a big issue.
Yeah, okay. And so maybe how do you see these new therapies, assuming that no major surprises like in the Tyvaso detailed data at ERS, how do you see these two agents competing? What's going to be your go-to new adjunctive treatment regimen? How you deal with those patients who just can't tolerate being on a backbone antifibrotic therapy? Will they just go on to a DOMI or a Tyvaso as a monotherapy until you have other combinations that you could go to, assuming future clinical development of some other program?
I mean, there are some developments underway that tolerability will probably be better, but I don't ever see us treating any of these diseases with just one drug. They're too complicated, and any complex disease that we take care of, whether it's heart failure, HIV, PAH, they all warrant combination therapy. Mm-hmm. So being able to balance the dose to minimize side effects will probably be fundamental. But I think the inhaled approach minimizes side effects because it's targeting the lung directly rather than systemically.
So an inhaled may be preferred over nerandomilast just because of in theory, the combination tox profile might look better to you. And
I would suspect so.
how do you then deal with the patient that just couldn't tolerate being on, say, an OFEV or an Esbriet? Are you saying that you might dose them down and then layer on top of that a treprostinil?
Well, the only downside of treprostinil is it's 4 times a day, although we started that dosing because that's what we do in pulmonary hypertension. Whether you have to do it 4 times a day in ILD, I don't think we'll probably ever study that, but you talk to any of our patients who are on the drug, none of them do it 4 times a day. So I suspect we'll be able to get efficacy without being such a burden.
Okay. And as part of the view, I'm just curious, nerandomilast had some drug-drug interactions with the higher, or I guess, and we saw the efficacy at the high dose.
Right.
And discontinuation rates were elevated in that combination. I imagine doctors want to use OFEV. It's the more preferred between OFEV and Esbriet. So how do you think about those drug-drug interaction issues and utilizing nerandomilast? Is nerandomilast going to have a viable role in the treatment of IPF, or did Tyvaso effectively leapfrog it through having a positive Teton trial study result?
No, I think that's a great question because one, efficacy was not as good. I would say it was modest. The side effect profile is pretty similar to the current OFEV and, pirfenidone and nintedanib. It's mostly GI and diarrhea, which can be difficult in upwards of 40% of the patients on the drug. So I think it's going to be one of these things where you try it. If the patient can tolerate it, you're going to continue it. I think efficacy-wise, it's pretty comparable to what's already available.
Mm-hmm. And so I think later this month we'll get detailed results from the Teton 2 trial. What is specifically your focus? Is it on tox? Is it on cough? You mentioned cough as sort of a legacy issue with that. I know that an IPF patient, I guess there was a concern they may be predisposed to cough as a side effect. So what are the sort of things that would be potentially rate limiting for you when you see the detailed data, be it from either efficacy in the monotherapy subgroup? I know like some people focus on that, or is it more about tolerability and cough?
I think it's going to be tolerability, but I would stress that we've got now better than 10, 15 years of experience with working with Tyvaso. And in the ILD population, we started the PH-ILD, it was before the pandemic, so we've got close to 7 years of experience there. And it's a rare patient that we can't get on the drug. And it's simple things. You can have them take some tea with honey, sometimes an inhaler, sometimes just a teaspoon of honey, and they can now inhale the drug. So it's not going to be hard to get people on it who need to be on it. Okay.
And then maybe just in terms of the clinical stage pipeline, we've got LPA1 antagonist, I should say. Bristol has some phase 3 data next year. That's I believe they've sort of looked to dial out some of the liver toxicities with the first generation drug in that class. That's probably the most advanced stage data readout. Is there anything else that you're focused on, and how promising do those look as potentially competitive entrants in the space?
Well, I think, as you point out, it's the second stage drug now. It looks like the hepatotoxicity is no longer an issue with this version. And the mechanism of action makes great sense as far as being an anti-fibrotic, anti-inflammatory, anti-proliferative. And tolerability looks pretty good. So I think since we have positive data from a phase 2 study moving into phase 3, and hopefully I think it's due out next year, I think it's very promising. And that's a drug where you could envision combining with inhaled treprostinil.
Okay. Alec, do you want to?
Yeah, great. So I do want to get our other panelists, Dr. Levy and Dr. Hersh, involved in the conversation. So maybe we can turn to bronchiectasis. So NCFB is a relatively large market, but a disease not many people have heard of given the historical lack of approvals. I guess how large is this market, and are there actually substrata of patients within this, say exacerbators and non-exacerbators, or is there another way you'd stratify these patients? If you could introduce yourself too. Thank
Hi,
you.
everyone. Bruce Levy. I'm also at the Brigham. I'm the Executive Vice Chair of Medicine there and was Chief of Pulmonary for about 10 years. So non-cystic fibrosis bronchiectasis is kind of a grab bag of clinical issues. And so bronchiectasis, of course, leads to scarring of the airways and somewhat of a dilatation. And people have a less effective cough to get rid of secretions. And so sometimes those secretions get infected, and patients can have respiratory decline in that sense. The neutrophil is the white blood cell that gets recruited into the lung and gets activated. Interestingly, Edwin Chilvers and the group at the UK did PET imaging studies of patients with bronchiectasis now probably a decade or more ago. They all had neutrophils in their secretions, but the PET study demonstrated that some patients were highly metabolically active, so the neutrophils were activated and the patients were quite symptomatic. And the new therapy, so the new kid on the block is Brinsupri, and that's an inhibitor of a protease that inhibits serine proteases, importantly neutrophil elastase, but others as well. And there's even some additional drugs candidates in the pipeline as well that have a similar mechanism. And so in patients that have this non-CF bronchiectasis, one would imagine that those with highly metabolically active and immunologically active neutrophil response would be the ones that might be best suited to responding to the drug. So there are going to be responders and non-responders almost certainly. This is really new. We don't have a lot of clinical experience yet with the drug, but for neutrophil over activation, this would be an opportunity for therapeutics. And it's the first really medicinal therapeutic that's targeting the bronchiectasis population. There's probably 300 to 500,000, maybe 1 million people with this bronchiectasis in the US, maybe more. Now that we have a drug, we'll find out. And the market may expand in that sense. But the underlying kind of etiologies of what's causing non-CF bronchiectasis is a wide array of things. And so I would imagine there'll be responders and non-responders. And clinically, we're going to start to sort that out. Okay. Maybe Craig would like to mention a few things about this interesting new therapeutic.
Yeah, I'm Craig Hersh. I'm a physician scientist at Brigham and Women's Hospital in the Channing Division of Network Medicine in the Pulmonary Division. I think, yeah, I agree with Bruce. This is sort of too new to know who will respond and not respond. But I think, the main thing of that, I think we're using the number 500,000 now, somewhere in between that. But like you said, probably get more. We still don't know what percentage of those are even just clinically the frequent exacerbators who would qualify for that drug. So I think we're already starting to cut down the sample size before we even get to those responders and non-responders of that. But those are all things we'll have to learn after the drug starts coming out and get some more information about that.
I agree. I mean, I still think it's probably in the $1 billion or more market range for therapeutics.
Okay, that makes sense. I guess what's been sort of the level of interest, either from your patients or the physician community more broadly, and as you're thinking about the launch, given it is a new drug and a first approval, any good disease analogs you'd compare to here, maybe CF or asthma?
You want to start?
Sure. I mean, I think it's going to probably, the use of the drug is probably going to follow the pattern that when asthma biologics first came out, and even to this day, that there's high use at academic medical centers, and then sort of minimal use in most community physicians, but sort of spikes of high prescribers. And I still think that the asthma biologics are still to that day, and part of that is just familiarity with medications, and part of it is just having infrastructure to do all the paperwork and prior auths that are required for a new expensive drug that may not be available for the solo practitioner or the small practice group, for example.
Makes sense. And I guess, now that we have the clinical data in hand and the label, are there any, holes in the data or efficacy left on the table for Brinsupri that could leave the door open, for fast followers? I know that there's a few other DPP1s in development, as well as Verona and others that could possibly compete.
I mean, there are cathepsin inhibitors that are coming, which may have a different range of action and potency. So I think it remains to be seen, but there's around a 20% reduction in the clinical trials with Brinsupri, so I definitely think that there's room for additional agents, especially those that might have slightly different targeting.
Okay. And I guess one more, and then I'll turn it back to Jason. Just ease of documenting through, attestation of 2 pulmonary exacerbations. Is this, a rate-limiting component of uptake in your view? And I guess any expectation for needing CT scans to secure coverage?
Yeah, I mean, I think, like I said before, the CT scans, especially in the academic centers, are everyone who has this diagnosis has a CT scan. It's just if they require within X number of years, that would be a change, but I don't think it's a real issue to get the CT scans. These are patients who have frequent contact with the medical system, so they're used to coming in for appointments. And similarly, I think places that have support to do all this paperwork should not have a problem documenting these 2 exacerbations a year. It's just that, like any new drug, all the authorization burdens, which will come out. But even, in the trials, these were 2, 3, 4. These were people with a lot of exacerbations per year, even though the drug may seem to look better in the milder disease. And I think that's another hole too, is what is it really going to look like in severe disease in the real world, as opposed to the clinical trial. But we'll have to see when we have some long-term data on that.
Yeah, I just want to add to, as it relates to the imaging, that clinicians frequently find themselves trying to distinguish between an exacerbation of the airway disease, of bronchiectasis, and actual pneumonia and more invasive infection that's now spreading. So imaging is quite common in the clinical care of these patients. So I don't think that'll be a barrier at all. Yeah.
Maybe we'll shift to pulmonary arterial hypertension and Dr. Waxman. This is a space that's been defined by polypharmacy, and Merck's Winrevair has been a popular new therapeutic. Maybe if you can contextualize how the introduction of Winrevair has altered your treatment algorithm, what it's meant for patients, and then as a follow-on to that, with the Hyperion trial reading out positively, how that will then look in the future to potentially move that therapeutic up earlier.
Yeah, so Winrevair or sotatercept has had I would say, a huge impact on how we manage patients. It's a whole new pathway which has opened the door for, I know they don't like to say it, but most of us in the field are talking about disease modification at this point. It's not going to eliminate the use of the pulmonary vasodilators, which have been the hallmark of therapy. And our approach has been that everybody, and both Hyperion, Zenith, and Stellar trials all were on stable background therapy, and that's been the approach. I think what's made it more interesting to care for these patients is that we're seeing patients improve dramatically with the addition of Winrevair. Although I still have to call it sotatercept, I can't do Winrevair, but such that we are taking them to the cath lab before we'll start the drug to make sure that they still have significant disease. We then start it. It takes a while for the drug to work, which is reflective of reverse remodeling. We do see an increase in hemoglobin fairly quickly, and that does make people feel better right away, but the real remodeling takes months, which is why we're never going to stop using the other drugs. But it does allow us to de-intensify therapy over time, and I like to think of it a lot like we manage cancer. in that we start up front multi-combination therapy and then back off once you get a positive result. And that's what's happening with the use of Winrevair.
What therapies are you de-intensifying? Are you having to use less parenteral treprostinil over time? If you can maybe speak to sort of what you scale back on.
No, what's been really interesting is the ability to first decrease the dose of the parenteral therapies, because patients will start to develop a high output state because they're over vasodilated. We can then back down on the dose of the parenteral drug and then convert them to oral in the case of treprostinil. And that's, I was the PI for the Spectre study, which was 20 patients all on multiple background therapies, and every single patient in that study we've been able to transition from IV therapy, down titrate, and over to oral therapy. So it's been an amazingly rewarding job with these studies.
Can you maybe frame the bleeding risk with Winrevair, how you view it? The upcoming Winrevair data, I know that I think the press release was similar to prior studies, right? Some of your peers said, I'm looking forward to seeing how the bleeding profile looks in earlier patients. They have a long-term extension trial, Soteria. So I'm just wondering how important are these data points to getting you, and I guess importantly, the broader community comfortable prescribing this more broadly?
Yeah, and full disclosure, I'm on the steering committee for all of these clinical trials. So the bleeding issues are predominantly epistaxis or nosebleeds. It's probably related to the development of telangiectasias, which are these spider vascular malformations that happen on the skin and probably also within the mucosa or the lining of the nose and pharynx and GI tract. What we've been seeing is that everyone develops the telangiectasias. Every single patient we've put on drug. Most of the time it's simply a cosmetic issue. Some people actually will get laser treatments for it. There is an increased incidence of nosebleeds, but it seems to level off. And what we've seen, same with the hemoglobin, is probably a combination of the two things, that it goes up fairly quickly. It stays up about 2 grams of hemoglobin, and that's probably stabilizes after about 6 months to a year. We have not seen, and the Soteria data is the long-term open label extension looking at safety and durability. We're now at 4 years. It'll be a 7-year study. The 1-year data has just been published, but we're not seeing an increase in incidence of epistaxis, so it seems to plateau out. Same with the hemoglobin.
So it doesn't sound like, in your view, this is a rate-limiting side effect or concern with the drug?
No. I mean, there are patients who come to us who already have pre-existing telangiectasias, some of our connective tissue disease patients. Those patients will have a discussion about the risk, and that may be a heightened risk in those patients, but obviously that's a minority of the patients.
So looking ahead to the ERS medical meeting later this month, the Hyperion study, that's Merck's trial looking at Winrevair in the front line. What are expectations going into that? The trial was stopped early. Will that have any impact perhaps on the result we see? How important is it to showing, is there any threshold hazard ratio that you want to see for this to become standard of care frontline?
So importantly, even though Hyperion was described as earlier disease, it was just earlier as far as relative to the time of diagnosis. It's not necessarily an earlier stage of disease. And the reason the Hyperion study was stopped early is because, as a steering committee with Zenith trial, which was a more advanced state of disease, the efficacy signal was so strong, we did not feel it was ethical to continue a placebo-controlled trial. So because of that, we also shut down Hyperion, and the DSMB also felt the same way. But what we have seen with the Hyperion, and again, it's time from diagnosis, we saw similar results of improvement, same side effect profile, same efficacy signal, but some of the data is a little bit dilute because we cut the study early, but it's still clearly a positive study. I don't think it's going to change the approach because everybody there was on background therapy, and we're still going to use that because that background therapy works more quickly, and then give time for sotatercept to have its effect.
So no real, I guess, bogey for success necessarily with the Hyperion trial, as long as it's presumably in the 0.6 or lower territory, that's a win for the study. It's probably a similar effect size as we've seen in a lot of kind of earlier stage patient trials.
Yeah, I would say it parallels everything we've seen all along the way from phase 2, 3, and now.
And as it gets used earlier and earlier, does that have a knock-on effect on delaying some of those other therapies or weaning off of maybe inhaled treprostinil or orals even?
I think it'll have an effect of removing therapies. We have taken away therapies in these patients who've been on drug for a while. I would say that the endothelin receptor antagonists are usually the easiest ones to take away because they tend to have side effects that we have to manage. The prostacyclins, I think, are harder to take away because they've really been the best drugs we've had until now. So it's a learning curve still.
Okay. And Insmed's TPIP, I'm not sure if you saw the update from Insmed, but their once daily prodrug of treprostinil and the potential promise of getting to higher effective doses with that therapeutic modality. Just kind of curious your views on that and how that could be potentially transformative in both PAH and Group 3 PH-ILD as well.
Yeah, so I'm chair of the DSMB for that.
You're everywhere
study.
in this space.
And the results obviously are very good. And to be able to take that drug once a day or twice a day, we'll see what happens with phase 3, but obviously it makes the world a whole lot easier for the patient. The drug is well tolerated. The efficacy, I can't imagine, will be any different from what we've seen with treprostinil. And obviously that means an application in not only PAH, but PH-ILD, and I expect PH-COPD as well.
And there was there was an issue raised by one of the competitors around baseline 6-minute walk and how that could potentially impact the results of what we saw with TPIP. I don't know if you put anything into that.
No,
Okay.
It's just a competitor.
And then one question from the field, and then I'll turn it to Alex for COPD, but I guess a question that we've gotten from someone in the field, for TPIP specifically, the ability for the prodrug to convert to active drug, especially if you may not have enough healthy tissue.
Yeah, I don't think we've seen that as a problem. I guess none of the tissue's healthy, unless you're asking about patients who have PH-ILD, but we've not seen an issue where there's a problem with conversion to active drug.
Okay. Alec?
Okay, great. So I guess our next stop on the tour of lung diseases is COPD. Maybe just to start, Dr. Levy and Dr. Hersh, how have the approvals of Dupixent and Nucala in the last year sort of changed standard of care for COPD?
Yeah.
I think Greg should start us off on
Sure.
this.
Yeah,
It's
I mean, I
his
think
area of
it's,
expertise.
I wouldn't say change standard of care. I mean, we're talking about a subset of COPD with high eosinophil, blood eosinophil counts, depending who you read, somewhere between 20 to 40% of people, probably, I believe it's probably on the lower edge of that, who then also have frequent exacerbations. So we're getting a subset of a subset where these drugs are effective. They're not nearly as effective in COPD as they are in asthma, which really, they're life-changing drugs in asthma. I think in COPD, it's another tool in our toolkit to help these people who really don't have limited options at that point.
Yeah, I would say that to just build on this, so patients that are having exacerbations on inhaled therapy, if they have peripheral blood eosinophilia, we think about this. We think about inhaled corticosteroids and adding that into the inhaled regimen, but it's those patients that we now are considering Dupixent and mepolizumab, Nucala. And there's some issues with thresholds. So like peripheral blood eosinophilia has to be higher to qualify to meet criteria for dupilumab than mepolizumab. It's lower for mepolizumab, still elevated, but lower. And then mepolizumab is once a month generally, and dupilumab is more like every 2 weeks in general. So there's some adoption by patient issues as we kind of talk through these options with patients. But if we think about these drugs and how successful they've been in asthma and now being introduced into COPD, it starts us to think about the airway and thinking about treatable traits as opposed to maybe some old definitions around how we categorize these conditions. So these conditions like asthma and COPD are quite syndromic, and this gives us a treatable trait that we now have biologics to address. And so it's been an exciting addition to the armamentarium, but as Craig mentioned, they're not, patients haven't responded quite in the same way in COPD as we have for the most part in severe asthma.
Okay, that's interesting. And I guess for the IL-33s, this was another class that had a lot of, hope behind it. We've seen some mixed results in COPD this year. When looking at something like itepekimab from Sanofi, which met its primary endpoint in only one of 2 phase 3 studies, is this kind of a non-starter for you, given the other options you have at your disposal?
Yeah, I mean, I think from both itepekimab and astegolimab, we only have the press releases. We don't really have the full data. And both drugs hit the primary endpoint in one trial and not in the trial with astegolimab. Obviously had the same numerical effect in both trials. So I think one thing that those of us in the field are really waiting to see is both these trials were done during the pandemic, is what's the baseline rate of events. So if you don't have, if your exacerbations dropped from 2 a year to less than 1 a year because of COVID, there's not much room to go lower. So that's what we're really waiting to see before we throw this drug class out completely. I think the other reason that people are still cautiously optimistic is that we're still waiting to hear about AstraZeneca's tozorakimab, which is going to, I think, read out next year, which they claim has a slightly different mechanism of action, a little bit higher affinity for IL-33 than itepekimab, and maybe changes the mechanism a bit because of that, or different binding sites. So people are still cautiously optimistic that there still may be a role for the IL-33 drugs in COPD. And I think the other things we have to see, for example, in the itepekimab, it looked like the effect waned over time, and Bruce is the immunology expert, but one of my colleagues who's an immunologist said if you shut off one part of the immune system, something else is going to turn on. So we really don't know what the longer term efficacy of these drugs will be in turning off this major pathway of defense in the airways.
Yeah, I agree with all that, and we see some of this waning efficacy with even the type 2 biologics. IL-33 in this context is released from damaged airway epithelial cells. And what we know is that people with COPD exacerbate for different reasons. Sometimes it's a viral infection, sometimes it's a bacterial infection, sometimes it's other reasons. And in asthma, one of the first descriptions of the sputum in asthma noted the presence of something called Crayola bodies, which are sloughed mucosal airway epithelial cells that find their way into the secretions that are then expectorated. And so it turns out viruses are particularly prone to have patients slough these epithelial cells. So one would think that that would be a time of increased IL-33 release in this context. Bacteria, maybe not so much. Depends on the bacteria. So I think part of the issue also with this area is when you're trying to understand COPD exacerbations and a treatment like IL-33, which really is targeting damaged epithelial cells, there may be, again, responders, non-responders, and we don't have proper biomarkers right now, but it may be that down the line we identify subsets of people where an anti-IL-33 approach is most active.
Okay. And I guess on IL-5s, this is Faserna, Nucala, definitely a bit more validated in asthma and rhinosinusitis. AstraZeneca is also expecting phase 3 data for Faserna in COPD later this year. Do you think it'll work given the recent approval of Nucala? And I guess what are your expectations around the clinical differentiation of these two assets?
Yeah, so I think, based on what I've seen of their clinical trial entry criteria with the higher eosinophil count, would expect it to work. And then we don't know until we see the data. I think then the big question will be, where does this, now that there'll be 3 drugs targeting this subtype of eosinophilic COPD, where does it fit into? But this is what the asthma specialists have been dealing with for 7, 8 years now. I think there might be some advantages for Fasenra, especially in the elderly population. The every 8-week dosing, once it's loaded, might be advantage for elderly people, especially people who may not be able to self-inject, maybe coming into the clinic. Just half as often might be an advantage. I think Fasenra is going to, get it. The only issue with that is this whole idea that Bruce brought up about treatable traits, and do we call it asthma or do we call it COPD? Fasenra is going to have a different dose for asthma versus COPD, which is also going to be then a question is where the price point is and where payers tier these different drugs and make you start another. If are they going to charge 3 times as much for 3 times the dose in COPD is a real question. We'll have to see what the data looks like and then how AstraZeneca starts to sell it.
I agree that it's likely to find efficacy. I would say in severe asthma, we had great anticipation that the mechanism of action of benralizumab would be superior over the direct neutralizing antibody approach of mepolizumab. And it hasn't really turned out that way clinically. If anything, we're finding that it's less active, but that's not rigorously studied head-to-head. The mechanism here for benralizumab is that the antibody has a fucosylated tail. It binds to the IL-5 receptor on a target cell, like the eosinophil, and then it relies on your cytotoxic NK cells, T cells, to kill that target. And I'm not sure that NK cells in COPD are exactly the same as they were in health or even in severe asthma. So I think we have to wait and see. The phase 2 trials with Fasenra were not super exciting, so I think it's definitely an open question. It's likely that it'll show some benefit, but as Craig was just mentioning, I think how it fits into the whole armamentarium of treating eosinophils and COPD remains to be seen.
Well, maybe we'll take, in the last couple minutes here, a couple questions from the audience here. So I'll bundle these 2 questions together because they're related, which is, what is your thoughts on the role of inhaled RNA treatments for rare and common lung disorders? And the follow-up to that is, what are the delivery issues for inhaled RNA therapies? And vaccines was thrown in there as well, but.
I don't know.
I think it's actually quite an exciting area, but I still think it's relatively young. There certainly are some monogenetic disorders that affect the lung. There's some really exciting bioengineering going on right now for delivery vehicles for RNA-based therapeutics in the lung that target different areas of the tree of the airways. So I think it's still early, but I think if you were to say what's going to be in the next 2 years, 3 years, kind of the next wave of therapeutics, I think we're talking about RNA delivery in that regard. And I think we'll start with some very rare monogenetic disorders for sure. But it's a great question. It's a really hot area. I've seen some really exciting early translational science here. And of course, there are companies that are innovating in this space. So hold on to that, because I think there's some interesting.
And the last question is something I feel like is applicable for everyone on the panel here, which is, what is the role of mucus plugging in IPF and bronchiectasis?
We've studied this quite a bit in severe asthma. We don't have a true class of therapeutics that are really targeting the pathologic mucus that we see in the airway. There's some, again, early stage companies that are looking at this and developing interesting therapeutics here. If you look at CAT scans and identify mucus plugging in severe asthma, it's more like Crohn's disease than ulcerative colitis. This is not kind of a uniform disorder of the airways. Rather, there are areas of the airway that are impacted, and some of those mucus plugs are there on CAT scans year after year after year. And the therapeutics that are being provided to the asthmatics are not resolving them. So there's a whole area of translational science that is studying the chemical characteristics of these abnormal mucus plugs, and there's drug development efforts underway to try to address that. I don't know if you want to say anything about COPD, because the COPD mucus plugging is a little bit different,
Yeah,
but
no, I
an
think
area of active research as well.
It's been very, very interesting. A lot of companies are very interested in using, doing phase 4 trials looking at especially the biologics in mucus plugging. And we know the association with mortality, so it's an important biomarker that we're learning, and it's not totally clear to me. Obviously, there's some part of that in COPD, or a lot of it is the consistency of the mucus and the production of mucus and the airway disease itself, but it also may be a marker of someone who has either systemic weakness, diaphragmatic weakness. For some reason, they just can't get the mucus up. So we may be, with this biomarker on CAT scan, sort of collapsing a few things together, which is useful for a clinical prognostic, but it remains to be seen how, if you treat it, does it actually cure the underlying problem or not? But a lot of that is just my speculation. We'll have to see if these drugs affect mucus plugging and effective exacerbations, then I think that would be showing a nice mechanism, at least for the airway part of it.
All right, well, we're up against time. So gentlemen, thank you so much for joining us and sharing your insights on this topic.
Thank you.
Thank you.
Thank you.